Hey guys, I'm Danielle Mascarenas. I'm one of the Pediatric Emergency Medicine Fellows at UNM. We are talking about pediatric rashes today. Objectives of this talk, so to recognize common pediatric rashes, know serious rashes, and discuss management and next steps of these rashes. So we'll start with the case. You are evaluating a 10-year-old female with a rash. She's complaining of diffuse joint pain and abdominal pain. She recently had a viral respiratory infection, no other significant past medical history, and no medication use. So you get a set of vitals and you have a temperature of 37.4, heart rate of 120, blood pressure of 95/70, respiratory rate of 16, oxygen saturation on room air is 98%. You look at your patient and she looks tired but is alert. She has dry lips, pupils are equal and responsive, her lungs are clear without any labored breathing. She's tachycardic, as we mentioned, with a heart rate of 120, no murmurs, and her abdomen is diffusely tender. You look at her skin and this is what you see. Both lower extremities are covered in all these red spots. You're not really sure what to think or what to do, and so you're wondering what's your next step. So rashes, where do we begin? A few things you should do when it comes to rashes. The first thing is to undress your kids if you can, so especially your little ones. They're not able to tell you anything about what's going on, if they're having pains in any particular spots, but what you can do is take a look at their skin from head to toe. You want to touch the rash. Make sure you're wearing gloves. You don't want to introduce infection and you don't want to catch anything. And you want to look for a pattern to the rash. So sometimes there's a pattern, sometimes there's just not, but it is important that if you do notice a pattern that you know what to do next, and we'll talk about this. You want to get a set of vitals. So what you're really looking for when you have rashes is you're looking for fever, tachycardia, hypotension, and you want to ask questions. So are there any new medications that the patient has started? Is there any history of allergies? Do we have any histories of past medical history that we need to know about? And have there been any recent illnesses? The one big question you have to ask yourself is, does the child appear ill? So in the end, if you have a rash and you have a child that looks ill, you want to do an immediate transport to a hospital. We'll come back to when we worry about rashes, but any child that looks sick, you want to take care of immediately. And you guys all know that, so I don't really need to say much about that. But the big question that I know that a lot of people worry about out in the field and that we worry about as providers is, when do we worry about these rashes and what do we do when we do find rashes that are worrisome? So when do I worry? So I try to divide this talk into ways that we can think about worrisome findings for a rash. And so I have several categories. We have 5 categories total. The first one being, does the rash blanch? So that means if you press on the skin itself and the skin turns white, that means that the rash sort of disappears, and that tells us that it's not as concerning. So if it does blanch, it's not concerning. If it doesn't blanch, then it is. Does the rash involve the mucosa? So the mucosa involves the eyes, the nose, the mouth, and the genitals. If you do have a rash that involves the mucosa, you're worried, and we can talk about why. And then you also want to ask another question, are there hives? The next category we look at is the rash vesicular or fluid-filled. We're worried if it is. Not always, but it can be something that's concerning. Does the rash slough or peel away? So that's the same word, the same term that we use, but we'll say slough for this terms of the presentation, but it really means, does the skin peel away? And then, is there a pattern to the rash, the lesions, the skin findings, or the bruises themselves? So our first category, does the rash blanch? The answer is no. Your rash might look like this. So we have a couple of pictures here to show a non-blanching rash. On the bottom photo that you guys will see, you have a glass that's clear and it's pressing on the skin itself. And so there's an area of white. That means that that part of the skin is blanching, but you still have a rash there and you have these red spots that are still there that are not blanching, and that's concerning. And what that means is that you have an area where essentially there's vessels that have released content into the skin, and that's a concerning finding on physical exam when you have rashes. The fancy terms that we use for this are Petechiae and Purpura. But really, you just have to identify, are these red spots going away when I press on them or not? And what does this mean? So Petechiae and Purpura can be concerning because it usually means 3 different categories that we have to worry about. The first being a vasculitis. Often this is autoimmune. The second being infection. So if you think about meningitis, you think about disseminated gonococcal disease. And then the third category under Petechiae and Purpura is hematologic or oncologic processes. So you think about if you have low platelets, which helps your blood clot, then you might have a bleeding disorder. And that for little kids can mean that it's possibly leukemia that we're worried about. But what do you do if you see this rash? So Petechiae and Purpura, like I said, can be some very concerning things. So when we're talking about meningitis or something that's disseminated in the blood, like gonococcal disease, you want to make sure that you protect yourself first when you're taking care of your patients. So you want to place on your respiratory and contact precautions when you see these rashes, simply because some of these illnesses or infections that cause these rashes are very contagious. Next, you do want to seek hospital evaluation for likely workup, admission, and possible medications. Because there's 3 different categories that can be pretty big and pretty broad. The next set of treatments or management that we would do would be potentially antibiotics, steroids, immunoglobulins, fluids, etc. But that part you don't have to worry about as much, but the important piece is to recognize that this is a concerning skin finding and that you should take this child to the hospital. The one that I wanted to mention, because it's really common and it's something that we see in pediatrics all the time when it comes to Petechiae and Purpura, is Iga Vasculitis. You don't necessarily have to remember this term or this diagnosis, but I mention it because it has a couple of classic findings with it. The old name, which I left in the photo just so you guys have it, is Hennig-Schleunlia purpura, which is HSP. Again, you don't have to memorize that name. But if you have Petechiae or Purpura of the lower extremities, it's not blanching when you press on it. You will usually see it on legs and buttocks. You will have essentially associated joint pain. You'll have abdominal pain. What you're worried about is that this is an autoimmune disorder, and this autoimmune disorder can lead to end-stage kidney function or kidney disease. And so there is treatment that we have to do for it. It is something that is easily treated, but the important part is to identify and recognize it before a kid can lead to chronic kidney disease. So again, it's called Iga Vasculitis. There's a lot to it in terms of how it develops, which isn't really important for this talk, but just recognizing it, knowing that it needs treatment is the important part. So that's our first category. Does it blanch? Petechiae, Purpura. The next category is the Rash Vesicular. If the answer is yes, it's going to look like this. So we typically describe this rash as rose petals or dewdrop on a rose petal, because it does look like it. If you look at it from a certain angle, it looks like little drops of water. What we most commonly see in this category is varicella or chickenpox. Typically when we see chickenpox in young kids, it looks like this. It's sort of spread out, discrete vesicles in different areas, usually on the trunk, can be anywhere. It's itchy. Is it life-threatening? Well, the question is a little vague. So the answer is overall no if you have a healthy child. However, we don't always know if the kids have some sort of immunocompromised state. So if they have chemotherapy on board, if they're on chronic steroids, they might be immunocompromised. And then this rash can be deadly and can be really serious. And we do have to give medications or antivirals for or immunoglobulins. But otherwise, the rash lasts about 3 to 7 days. You typically have a few days of fever, and then you do worry about bacterial infection. However, in this case, it doesn't look like it for this kid that I showed you, but it is something that is possible. The next vesicular rash that we think about is hand, foot, and mouth disease. So this is a really common rash that a lot of families come in for. So vesicles on the feet and the hands, typically on the mouth. You usually see them on the back of the tongue, but you might see them on the lips and the face. This child happens to have a pretty disseminated hand, foot, and mouth disease. So you see that the vesicles have reached up the upper extremities, up the lower extremities, and then again, you can see it on outside of the mouth as well, which isn't always typical. But this case is one that would likely need admission. Why? Well, the biggest thing that we worry about with these rashes is dehydration. So it's painful. Kids don't want to drink. They get dehydrated pretty quickly. We usually have to give IV fluids. It'd be totally fine if you started fluids within the field, and then we would continue it if they came to the hospital. And we'll sometimes use viscous lidocaine. Only in the ED, we'll add a little bit of lidocaine onto the vesicles so it's less painful. It's caused by Coxsackie virus and enteroviruses, which you don't really need to worry about too much because there's not treatment for it. So all the care that we do is supportive, but oftentimes kids get sick enough to where they do need that extra level of support. The next vesicular rash that we worry about is Eczema Herpeticum. So eczema, a lot of us know about. Typically, we will have areas of dry skin or skin that's already somewhat diseased. So you'll have it on the inside of your elbows, on the back of your knees. Kids will often have it on their cheeks or they'll have it on their chest. So what we're worried about in this case is herpes virus that has gotten into the diseased part of the skin, and it's caused potentially mild to life-threatening infection. So kids do need to be treated for Eczema Herpeticum. Typically, we can do oral antivirals or acyclovir. However, these kids sometimes do need IV acyclovir. They need fluids, and they do need to be monitored in the hospital. So if you have a child that has vesicles, particularly located on certain areas of already their skin disease, we're worried about it, and we want to see them in the hospital too. So we've talked about our Petechiae and Purpura. We've talked about our vesicles. Next, we're going to talk about the mucosa. So this is another category that I say, if there's mucosal involvement, we're worried about the child and you do want them to come to the hospital. So again, mucosa involves the nares of the nose, the mouth, the tongue, the eyes, and the genitals. What also this means is that if we have mucosa that's being affected that we can see, we worry about the mucosa that we can't see, which is in the rest of the GI tract, and that's a huge surface area. So that's why it's scary. This one here is called Stevens-Johnson syndrome. So it involves the mucosa of the mouth here and the eyes. And I'll tell you a little bit about that. So Stevens-Johnson's and toxic epidermal necrolysis is the same disease, but on a spectrum. You have SJS, which is less than 10%, and TEN, which is greater than 30%. Typically, the disease that is caused here is that you're having the skin essentially necrose and detach from the dermis. So what that means is it can cause problems for the pulmonary system, the GI system, and anywhere else along the body, like I said, from the GI tract. Medication is the leading cause, about 70%, but 30% of the cases are unclear of why we have it. You do treat it like a burn. You do fluids, wound care, pain control, and you may need a burn center. The biggest thing you do, though, is stop the offending agent. Next, we have mucosal involvement that causes swelling. So if you think about the swelling of the lips and the tongue, then you worry about allergic reaction. You look for hives or urticaria. It can be confluent or it can be separate areas, and it changes positions. Here's another picture. This one is Urticaria multiforme that has a surrounding area that's red, but in the center is a little dusky. It can be very itchy. Why do we worry about this? Well, most commonly it's caused by a viral infection, not as concerning. But if it's a serious allergic reaction, it's anaphylaxis. And we worry about wheezing, shortness of breath, and hypotension. So you want to give epinephrine. You can give 0.15 milligrams or 0.3 milligrams, and you do it via an EpiPen IM. That was our last category. Does it involve the mucosa? Are there hives? If it involves mucosa, we're worried regardless. If it involves hives, we might need to give epinephrine for an anaphylactic reaction. Our next category is, does it slough? If the answer is yes, we're worried. What is sloughing again? Well, essentially, it's the peeling away of the skin, that top layer. So the other term is desquamation. Nikolsky sign is where if you place your finger on the skin and you press on it and it essentially peels away, that's a positive Nikolsky sign, which is concerning. The biggest reason for having this sloughing of the skin is staph scalded skin syndrome. This is for pediatric patients in particular. It's similar to a burn and it looks like a burn. So I think if you saw this child, you'd be worried about a burn regardless, but you also want to think about the fact that this could be an infection. So Staph scalded skin syndrome is associated with Staph aureus. It's usually kids less than 5 years of age. The rash typically starts off as like a fine sandpaper rash. So if you touch it, you can feel it, small red bumps. Gets really red and then it starts peeling away or sloughing off. This does not involve the mucosa, so that's a good thing to know because if it did, it would be in our other category. You would give antibiotics, fluids, and you would possibly transfer to a burn center as well. The next section or group that I like to talk about, is there a pattern to the skin findings? If there is, then we want to worry about abuse. The other term for this is non-accidental trauma, or NAT. NAT should be suspected in any child that is non-ambulatory. So any bruising, that in a child that is non-ambulatory. A child less than 4 months of age is non-ambulatory without question, and so should be considered trauma. Any pattern bruising or skin findings are also suspicious, and this can include things like a belt buckle, cigarette burns, etc. Here is a really nice diagram of things that show intentional injury. So you see belt buckles there, you see cigarette burns, etc. Anything that's an immersion burn would be concerning too. I like this slide because I think it's really helpful to show what things look like. Sometimes we can be wrong, but it's nice to know that if there's something that looks a little off and it looks something similar here, you want to say that you're concerned enough to get evaluated. My rash doesn't fall into these categories. That's good. What are we worried about? Well, less likely worried. We're thinking potentially this is a diaper dermatitis, which can look like this. You have contact dermatitis, can be a physical irritant. Increased moisture, change in pH can cause problems, but basically you just do a barrier cream or ointment. I like Vaseline, but you have butt paste and you have Aquaphor. Candidal diaper rash can be beefy red appearance, involves skin folds. You often just do nystatin and your barrier cream. Roseola. So this is a typical rash that involves fever. You have 3 to 5 days of fever and then the rash. Doesn't really do much, self-limited. It's blanchable. And then viral exanthem. In this case, we have lots of viruses that can cause this. Can be kind of bumpy, can be red. But overall, the kid looks good and it's self-limited. Blanches as well. Erythema multiforme causes target lesions. Can be red. In the middle, it looks like a target, so a little clearing, small red dot. Can be raised or flat. It's often misdiagnosed because it can be seen with SJS or TEN. However, there's no mucosal involvement. Treatment is also supportive. So back to our case, we noted that this was Petechiae and Purpura. We didn't know exactly the diagnosis, but we knew it was concerning enough to take the child to the hospital. The child got several days of immunoglobulin, did fine, no kidney dysfunction, was able to go home. So our final reminders. Any rash with fever and hypotension is serious. It's a systemic infection and could be deadly. Any rash in the very young or immunocompromised can be dangerous. Any skin findings that look patterned or bruising of a non-ambulatory child might be abuse, and we should get the child evaluated further. So here are my set of resources. I have everything listed here. There's some nice places on here that you can click that will show you pictures of different types of rashes in case you come across something that doesn't look quite like what we showed you. But I also am open to questions. You can email anytime, you can call me. Kim Pruitt has my phone number. You guys can touch base directly as well, and hopefully we can answer some questions for you.